Hi, I'm Dr. Sai Madhusree, Consultant Radiologist and co-founder of True Med Diagnostics and Clinics, Kondapur. Today's podcast is to create awareness on early detection of breast cancer. For that, I have two eminent specialists and my dear friends. For that, I have two of my best friends, and I feel so proud and privileged to have you both. They both are eminent specialists in their respective fields. One is a breast pathologist and one is a breast radiologist, and have so many publications to their credit. She is a professor of pathology in University of California, based in US, and Srikala is a well-known radiologist in Twin Cities, and she is the chief radiologist of Sindhu Hospitals, and previously served as chief radiologist in KIMS Secunderabad too. I welcome you both, and I'm actually so grateful that you have obliged for this.
It's the same feeling here. Thank you.
So, as you know, breast cancer is one of the most common cause of cancers worldwide. So, and it is one of the common causes of cancer deaths. Is it so?
Yes. And there is a concern that particularly in India, as compared to other countries, the similar trends, by 2050, we are going to have a substantial rise in the breast cancers, particularly in the young women.
Young women.
Yeah.
What is the incidence of breast cancer in India, Srikala?
To be precise, we do not have a very robust registry in India, unfortunately. So, in whatever information that ICMR could gather, now they say that in urban women in the age group of 40 to 60, the incidence is about 1 in 22 to 1 in 24. And in rural, they say is 1 in 60. But in the last decade or so, the numbers are enormous. Easy, we have more than 2.5 to 3 lakh cases every year, and about 50% deaths because of the breast cancer. And I think even the rural and urban divide is getting closer because of the change in lifestyle,
urbanization,
population. You know, the food they eat, and in terms of their physical exercise and lifestyle, because even the rural women, the lifestyles have changed. So the divide is not very wide, is what we think. Yeah, but then of course there is always opportunity to get good data. But and in fact, there was a recent paper that came out of Chandigarh and Punjab, which said 1 in 8.
1 in 8.
Alarming and on par with the Western counterparts.
Yeah,
In India, we always thought, breast cancer is not very common.
Not
It's
very
only in
prevalent.
Caucasian women. But no, I mean, this small study that came out from Chandigarh put the numbers on par with the West. So, yeah, there's lots happening, there are lots of cases, but I think many go unreported. But I must say that, in the 20 years that I've been practicing, breast cancer numbers are rising by the day.
So, what's the incidence in US?
So that characteristic number that you have mentioned, 1 in 8, has been there ever since like 30, 40 years ago. It continues to play the same thing, 1 in 8 women. But I feel like from my experience for 30 plus years, it's probably is 1 in 5. And now I see a trend of Indian women who are migrated to US also having the breast cancer. So that is concerning as well. So,
in spite of US being a developed country, the figures are quite high. So, yeah. So, coming to the guidelines, I initially thought that universally it should be the same, but then after talking to you, I realized to my surprise that the guidelines are different in US and India. Is it so? So, what are the guidelines that we follow in India for screening mammography, which is considered to be the tool for detection of early breast cancer? Srikala?
So basically, what is screening? What do you mean when you do a cancer screening? You mean that you're going to pick up the cancer before the patient has any symptoms. So, in India for years, we've been doing pap smear for cervical cancer, and we know that as a result of doing pap smear, we picked up CA cervix. In fact, not even CA cervix, a stage prior to that, becoming
in situ.
In situ. And then we were able to bring down the cancer cervix numbers in the country. Similarly, in the West realized way back in late 80s and in early 90s that if you did mammographic screening for women, you picked up these non-palpable meaning neither the patient can feel it nor the surgeon can feel the lump, which means you're picking up a breast cancer as small as 1 centimeter or even lesser. So they realized that mammographic screening was picking up these cancers very early and you were able to save lives. Now, having said that, one must understand that screening only picks up cancer early. Screening cannot prevent a cancer from happening.
Exactly.
Right?
Exactly.
So, but unfortunately, because in India, we are 1 billion people and we are still grappling with a lot of infectious diseases, maternal mortality, and our healthcare for a public is not that robust. We do not have breast cancer screening program because yes, we haven't reached those numbers. So what we call in India is opportunistic screening, where a woman reads about the benefits of mammography and she comes forward to get a mammogram done. And the doctor talks to her and tells her whether she's fine or, if she needs another ultrasound to act followed. And that's how things are happening in India. So if you ask me what are the guidelines, we actually, for Indian women, we do not have any guidelines.
Any such guidelines?
Yes. But because more and more data is telling us that Indian women are presenting with breast cancer 1 decade earlier than the Caucasian women. So if the peak age is say 55 or 57 in America and UK, Indian women are peaking at the age between 45 to 50. In fact, one of the papers says it's about 47. So we as practitioners are advocating that between 40 and 60, one should do an annual mammography. And after 60, probably a biennial, once in 2 years.
2 years.
Now, because in the US, I'm sure it's an annual mammogram after 40.
Yeah, the 40. Yeah. But after 50, you can go into biennial mammography.
Yeah.
What's the cutoff age?
Honestly, there's no cutoff age as such, but
way to stop.
70. NHS stops at 72. NHS is English.
UK.
So they used to stop at 70, but now they've increased it to 72. They used to start at 50, they've decreased it to 48. So globally, there is a trend of breast cancer coming in younger women. As you see, because NHS also brought the age down to 48. In US, anyways, starts from 40. So in India, because we have evidence that it's in younger women, we are advising annual mammogram from 40 to 60. And then after 60, they can do it once in 2 years if they do not have other risk
factors as such.
Yeah, I just want to add one more thing here because I conducted 2 breast cancer symposiums in Bangalore. And so one of the things from ICMR is that at that time, someone represented to come to the symposium. We are late in the game, actually, to me, India, because part of it is more social, that we haven't accepted the breast cancer as it is.
Very true.
And the other thing is like we lack the data, as you said. Absolutely. So there's a huge rural population that we are not able to follow these women. And one of the things they said was that these women come for screening or treatments and they leave. Part of it is because of the families and stuff like that. So we don't have enough follow-up data to create a screening program for these women. But I'm glad that at least you took the adoption from the other countries and using that, UK and US.
So mostly urban, semi-urban, say tier 2. It's more opportunistic.
Yes,
exactly.
A neighbor gets it done. Says that it's important.
That is amazing.
The woman comes forward.
I think this podcast will also be useful to fill
Exactly. That's what it is meant for. Exactly. Yeah. So coming to the prerequisites, what are the prerequisites that a woman should have before she opts for a screening mammogram?
So they're pretty simple. Okay, the women actually have to mention their pregnancy status to the women, to the person who's doing that, and part of it is like not when you enter the office, not having any deodorants or anything that would cause some kind of artifacts on the images, and even on biopsies also you create that. Okay, so you don't want to have a false positive or false negative stuff, and wearing the loose clothes, obviously, for the thing. And most importantly, you need to have the prior history. If the patient has any kind of prior history, is something that if they can bring all the reports. For us, we have reports, everything tricking from the EMRs. So, that's something that...
One more most important thing is most of them complain of pain during mammograms. That's because they're not being informed the correct time when they should actually go for the mammogram.
Yeah.
So it should...
Yeah. So
Can you...
see, every woman goes through her menstrual cycle. And one must understand that the breast follows the ovaries, because every ovulation, the body is preparing for a potential pregnancy. So the breast also undergoes changes, and it's also preparing for pregnancy.
Exactly.
So once the body knows it's not pregnant, so the changes again revert back to the baseline. So these changes tend to cause some soreness and pain.
Obviously.
More so in the second half.
Right.
So we always say that when you go for a screening mammogram, do it in the first week after your menstrual cycle. So once you finish your cycle, then the following week go for the mammography, so that you're more comfortable.
Yeah. And you don't really...
Mammogram involves, compressing the breast under 2 plates. So it causes some amount of discomfort. I wouldn't say really pain, but some kind of discomfort.
Yeah.
So if you want to avoid that, then a week after you finish your cycle would be
most ideal. Yeah. That's the most ideal time.
I would also like to add that the painful mammogram era is actually over, thankfully, to the digital
mammography. Yeah, with the advent of these...
digital technology is very forgiving. So even if I don't get the most ideal compression, I don't really squeeze it that hard, I still get
to see
quality images. So now we just compress as much as the woman can tolerate and take a mammogram of good quality. So I think that painful mammogram where the breast is getting squashed between plates, I think we're over that.
Era is over.
More advanced technology.
Nice. So, Srikala, you've been practicing breast radiology for so many years. Did you come across a scenario where you thought a cancer has been missed because of bad machinery, a bad resolution of the poor resolution of mammogram, or inadequately reported, it being inadequately reported, or because of bad technique, whatever? So what is the checklist that you offer for a woman who opts to go for a screening mammogram?
Yeah, that I think is a very, very appropriate question, because just going and doing a mammogram is not enough. And for a center, just putting up any other machine is not enough, right? So digital mammography, this is the era of digital radiography, whether it's an X-ray. Basically, mammogram is nothing but an X-ray of the breast. It's a soft tissue X-ray.
Exactly.
So make sure that you're undergoing a mammography in a system which is digital, not computerized. It's a true digital mammogram system, because it gives exquisite quality, and the amount of radiation required to get good quality images is far lesser than the conventional machines, right? So that's important. Number 2, the eyes behind the machine are as important. So you have to make sure that the radiologist who is reporting these mammograms has had enough experience in looking at these, does enough numbers, because I'm as good as the number of mammograms I report.
Exactly.
I only
directly proportional.
Like anybody, like practice.
Exactly.
So if I practice more, I become better at it. So if I read more mammograms, I get better at it. So make sure that the center has a senior radiologist who is used to it, who is trained in looking at mammograms.
Exactly.
There can be a very senior radiologist, but who looks at brains all day. no good. The radiologist who's reporting your mammograms should be good and experienced in that particular field.
Exactly.
And of course, the technologist who performs the mammogram should also be skilled, because I'm as good as the amount of tissue that my technologist includes in the images. So she should position it well for me to report it well. So
True.
these are the three most important things that
Important
one
things.
has to check before they're going in for a mammogram in the sector.
Yeah, thank you so much. That's a real good advice,
Yeah,
right?
definitely.
Because
Definitely.
see, many centers have come up offering mammograms at a throwaway price, but then it shouldn't be an eyewash thing for them.
Absolutely.
Yeah.
It should be.
Of doing
Yeah.
It's just for the sake of doing it.
Because telling a woman who actually has a cancer that she doesn't have one is, I
An
think,
absolute
it's a crime.
crime.
You're reassuring them when they're actually suffering, which is
Exactly.
just not right.
That's
Right.
absolutely
So that's
true.
more harm than good.
You're good.
You know?
Exactly. You better say, I
Yeah.
don't know, rather
Yeah.
than.
Yeah, right.
Yeah,
That's
that's
true.
Yeah.
Yeah.
So coming to hereditary cancers, which is much talked about. So hereditary cancers, logically speaking, the incidence is same universally, or
So when you talk about hereditary cancers, you're associating with a gene called the BRCA, BRCA. Okay. So traditionally, I have to go back a little bit into the history of it, how this whole thing panned out. Okay. Around 2006, Dr. Chuck Perot from University of North Carolina, he presented at San Antonio Breast Cancer Symposium. He has done a gene analysis of all comers of huge cohort of breast cancers, and he divided. We cannot call it what we traditionally are calling it, so we need to go by the biology of these breast cancers. So he divided them into four: luminal A, luminal B, luminal pure HER2 cancers, and then triple negative cancers. So when he did the heat maps, the triple negative breast cancers carried a significant amount of BRCA association. So now when you talk about 1 in 8, either in India or back in US, we are talking about 20% of the women are having the triple negative breast cancers. And as you said, when you look at the recent papers from any of these big institutions in India, they are also quoting that 20% of women having the hereditary cancers. But then you have 80% which are more sporadic.
Yeah. So it's basically 20% are hereditary cancers, and it's the same incidence. Even it's universally it's similar.
Yeah.
So how do you go about the genetic testing? What do you and whom would you refer for genetic testing, and when?
So it's quite different from India, right? So our practices are, so what happens is a woman diagnosed with a triple negative breast cancer. So to the audience, what is triple negative breast cancer is the tumor does not produce any kind of estrogen, progesterone, or HER2. So it is really hard to treat these women, and particularly with no target towards the receptors. So all these women, what happens is that you present at a tumor board. Okay, so we have a weekly tumor boards when the radiologist, it's a multidisciplinary tumor board, and we discuss. And it's a triple negative breast cancer, young women. Then the genetic counselor is also in the heart of the setting, and then so they go for the genetic testing. So in that way, we cover them and talk about the family tree and everything. So
No. What are the genetic tests that you offer to whom? Like if a woman with a family history of breast cancer comes to you for counseling, so what would you?
Now it's actually not just BRCA. You're also looking at P50 deletion.
Exactly.
So there are over 30 gene array that is now advised to get done. Because
Okay.
earlier we used to think it's only BRCA
1 and
but now
2.
we realize there are many more gene deletions and problems which can manifest as breast cancers or lead to breast cancer. So we now advise for a multi-gene panel which would cover this, all these syndromes, the familial cancer syndromes. So we advise that one should get that done. Now, earlier, this used to be very expensive in India. In US, it's a different thing. It's all insurance.
Insurance, yeah.
Whereas in India, this impact, as she said, early 2010, 11, BRCA itself used to cost us 3.5 lakhs, and
Yeah,
it was not available in
yeah.
cities
India.
like Hyderabad also.
It was
In
only
India.
in
We had to
Mumbai.
take the
Yeah.
sample to Bombay.
Bombay.
For a BRCA, for a family cancer in 2007.
Yeah. So, how do you go about genetic testing in a woman with family history of breast cancer?
So we send out the genetic testing, and as you mentioned, it has evolved, just not the BRCA thing. We sequence the BRCA gene, but there are some consequences of this sequencing. Only the genetic counselor can really interpret that with the family and with the physicians involved in the breast cancer care of the patient. And some of these don't have targeted drugs, so they do take out all those little mutations or mutations and everything, but they focus on the major part of the BRCA stuff. So,
Yeah.
In India, what's the scenario?
India, when we see that a lady has presented very early with breast cancer, that's when, say, a below 40 or even in early 40s, when it's a triple negative breast cancer, as doctor mentioned earlier. So whenever the diagnosis is of a triple negative breast cancer, no matter what the age, we advise a genetic test. And in non-triple negative, say a luminal or a HER2 positive cancers, if the woman is young, say around 40 or below 40, then we advise that they should go in for genetic test. Yeah. So, and then if a lady comes with this, telling us that her mother has had breast cancer, her aunt had ovarian cancer, and whether she should get it done or not, then we tell them, because breast and ovary are related.
Connect.
So then we say that yes, they might be needing a genetic evaluation.
So, do you advise genetic testing even for a boy? Like, if the mother has a breast cancer at a very young age.
Yes, there is.
If she has a son,
Yes.
because there is equal incidence of male breast cancer.
Yeah, that's a nice question to ask, because when we talk about breast cancer,
You only talk about the
women get affected by it. But
Exactly.
no, male breast cancer is a very well-known entity, and we do see it. It's not very uncommon, and especially so if the mother has had breast cancer early, then the chance that the boy can have a breast cancer or prostate cancer is high. So prostate and breast are related cancers genetically. So yes, it is important that even the males get testing done. And conversely, if there is a male breast cancer in the family, no matter what the age, the women, the daughters are going to be straight into the high risk category. High risk meaning 20 to 25% lifetime risk of developing breast cancer.
That high.
So if the father, even if he were 65 or 70 and developed the breast cancer, the daughters are high risk no matter what. So that's how they're related.
So, at what age do you advise genetic testing for the male?
Has had breast cancer in the 40s.
Young age? No, below 40.
Below 40.
With triple negative.
The boy can have a testing done. In fact, the same as we tell the girls.
Girls,
at
okay.
25 to 30, you
25
get
to
a
30.
genetic testing done. Because there is some evidence to show that some medicines can push
the occurrence of breast cancer. Right.
So there is something called a chemo prevention is also coming up.
That's a new thing that I've heard.
So that way, like they can be put, especially in women, they're sometimes put on tamoxifen, anti-estrogen drugs to for women who are known to have genetic predisposition. So yes, chemo prevention is available. So before they turn 30, they can get the genetic testing done.
Okay.
And it's also not just that the children get done, but if the woman has presented early, then it's important that the index case gets the genetic testing first. So in case she is negative for any gene, then it's unlikely that the children are carrying it. So the index case has to have the testing done first. But many times what happens is 20, 30 years ago, we never had all these tests.
Exactly.
So say today's woman who's 35 or 40 comes and says, my mother passed away 15 years ago when she was say about 40 with breast cancer. So we tell them what she tested, and obviously she wouldn't have been tested.
Yeah,
So
obviously.
then we say, okay, I think you should go ahead and get yourself
Get
tested.
tested.
The mother was very ill.
This is
Yes.
something very, very new, and thank you so much,
Yeah,
actually.
I just want to give the little bit different opinion on the BRCA, how we do it. There are two genes, BRCA1 and BRCA2. So they have a propensity to develop breast cancers and also pancreatic cancers as well. And there's a small, if it's a male, it's prostate cancer as well as the breast cancer. So we decide at the multidisciplinary tumor board, it's all to do with the multidisciplinary tumor board. That's where we decide who gets the genetic testing, who doesn't get the genetic testing. But anyone of the 40, below 40, everyone with the in situ cancer, like it's called ductal carcinoma in situ, as well as invasive cancers, you get the genetic testing. Okay, so so that we cover everyone in that particular area. For the males, it's the cancers present little bit more earlier because of the skin to the breast tissue is very thin. So they present with larger cancers, but they do have a propensity to develop a well-differentiated cancers. But any male presenting with anything, they get, the entire family gets tested. But at the same time, prostate is more common compared to breast. And they tend, if anyone with a prostate cancer and with a family history or basically all the prostate cancer, also some of these people have the multidisciplinary tumor boards and they test the BRCA gene on these people as well. So,
So, I mean, if somebody has a prostate cancer, then going back is still not very established. But yes, but if you've done a BRCA, then the possibility to work up for a prostate
is
unfortunately, we don't have a pancreatic screen.
Yes.
That's all.
So coming to imaging in hereditary cancers, how do you go about?
So normally, if the woman, say the mother had breast cancer at 40, then we advise that the daughters are screened 5 years prior to the index case.
35.
So the first case in the family is called the index case. So we say that if the mother has had cancer at 40, then the daughter starts screening at 35. Now, suppose they're BRCA positive, like the mother and the daughter are BRCA positive, then mammography alone is not sufficient. So, in fact, there is evidence to show that we can start screening from the age of 30 with mammogram and MRI done alternately every 6 months. So, say you do a mammogram in January, we advise an MRI in June, and then mammogram in the next January. So every 6 months, the woman is seeing the radiologist. Because the likelihood of these people developing breast cancer is almost 75%. It's very, very high.
Quite high.
So there is still no evidence to start mammogram earlier than 30. So maybe if they are very anxious, we can start doing breast MRI for them, because
reproductive age group,
that the breast is very dense in young women. So dense meaning the breast tissue is white. Cancer also looks white.
Correct.
White and white is very difficult to pick up on imaging. So that's why, because MRI has very high sensitivity to pick up breast cancer. So that's the reason we add MR also in these women, because they're very young and their breasts are very dense. So we alternate MRI and mammograms. So below 30, we don't advise mammography. If they are BRCA positive and they are very, very worried, then we start doing MRIs for them. MRI and ultrasound. Because mammography does have a slight, it is radiation at the end of the day.
Correct.
So we try and not expose them to radiation until they are at least 30 years old. So we can start MRIs, and from 30 we can start mammogram and MRI also.
So why not only MRI? Why mammography from 30? Because of late, all the women are career driven, and then late marriages, and they don't complete their family by 30. Unlike previous ages, previous period, how do you, why mammo? Why not only MRI?
See, the thing is that MR is not such an easy investigation to undergo as well as interpret.
Oh,
So there's a long learning curve
limitations.
to a
Right.
radiologist being able to interpret MRI.
MRI.
And number two, also, it's not a very easy investigation to do every 6 months. You know?
Exactly.
It's expensive.
Expensive.
And
yeah.
the know-how and the capability is not available everywhere.
Everywhere. Exactly.
See, when you do a breast MRI, it's not like a brain study. You need a
Correct.
dedicated breast coil,
Coil.
which
Yeah.
not every center which has MRI will have it with them. Right? So
I
it's
know.
the technology, the technique, and also the radiologist and the patient also. It's not such an easy investigation to go through because we
through.
do give contrast.
Correct.
Gadolinium.
Correct. Correct.
Now, there are many studies now coming up about gadolinium deposition in the body. So that has
Oh.
its own
No.
long-term side effects.
Correct.
So to keep everything in balance, we
Mm.
alternate mammogram with
and MR. Okay.
Yeah, for us, like the point here is when you call a screening test, okay, it has to be available to everyone.
Everyone. Exactly.
So it should not be expensive, okay? And we have guidelines for MRI, which is when the patient is diagnosed with cancer, we want to look at the entire breast to see if this is a multifocal, multicentric disease, okay? So for that, so we have certain guidelines for when to do the MRI, like for dense breasts, okay? So sometimes lobular cancers cannot be missed,
Yeah.
or even ductal cancers were missed. So for those patients, we additionally do the MRI testing. So with all those guidelines, MRI was never approved for screening as a screening tool.
Exactly.
Yeah.
But like,
Today, it is in the high risk screening.
high risk
Mark
screening,
figures
that's what
only in
we are right
Yeah.
now talking about,
Yeah.
high risk screening, because when we're talking about hereditary cancers, that's what. So coming to this, celebrities undergoing bilateral mastectomy, prophylactic, that's something. So we have heard of Angelina Jolie, and we have recently heard about our own Hyderabad doctor. I don't think I can mention the name, but she openly came out and said that I better not get diagnosed with a cancer rather than I undergo. See, actually, so brave on their part to come out openly, because it's something people will catch attention immediately and they get to know about. So what's your take on that?
So celebrities coming and educating people on their treatment tools has been highly effective, okay? Female or male for prostate screening, Ben Stiller has come out and talked about it. But the Jolene effect has been a huge impact for women. Part of the reason is that she tested positive for BRCA because her mom had breast cancer. So when you have a BRCA strong association with a first degree relative, which is mother, grandmother, everyone having the breast cancers, there is a high incidence of risk of having breast cancer or ovarian cancer and primary peritoneal cancer. So all these, and which come from the fallopian tube. So for these prophylactic cancers, to prophylactically prevent all this stuff, these women undergo bilateral mastectomies, bilateral salpingo oophorectomies, and they do the peritoneal sampling as well. So in that way, she educated a lot of women who did not know that they were the BRCA carriers or there can be something done in these situations. In that way, I really congratulate Jolene for doing this stuff. But at the same time, there was a huge rush among people in the hospitals. Am I BRCA positive? Am I BRCA positive? You know, in that way. But I'd rather have that one rather than missing out on
At least that's such a good thing.
Yeah. And
See, awareness is good, scare is bad.
Bad.
So we have to draw the line. somewhere. And yes, it's called the Jolie effect, where in fact, I remember we had diagnosed a 6 millimeter cancer in a 40 D cup breast, and the woman chose to have bilateral mastectomy.
Oh.
You know, we picked up a 6 millimeter
6
cancer
millimeter.
in the right breast in a well-endowed lady, and she said, "I want to knock out both my breasts." So that's then okay.
Oh, yeah, yeah.
So
Absolutely.
Too much of
Too much
is not right.
Not right.
Yes,
Yeah.
BRCA1, they carry a 75% lifetime risk. So it's ultimately it's their body, their calls.
Of course.
And each to his own.
Yeah.
Yes, so you had to kind of weigh the pros and cons. Imagine at 30, you're getting your ovaries knocked out, you're going to be on HRT, your bones are going to become very
Brittle heart.
So you
at
have
risk.
to really weigh the pros and cons and take a correct decision. And I think the treating surgeon, the geneticist, all of your family members should be a part of this
Journey,
decision.
Yeah, we have offered egg banks, fixing the eggs for these women.
Yes.
So
It's catching up here too. Yeah.
So they do that for the patients if they want to. So.
See, infertility is on the rise, and you see so many young women undergoing so many cycles of IVF. So, do you have specific recommendations for this younger lot? Because for screening, do they need to undergo screening earlier than when compared to general population? I'm not talking about the risk or the hereditary risk or whatever. It's just, do you have any specific recommendations?
Because to treat them any differently, but having said that, we know that they're being exposed to very, very high amounts of estrogens in their life. So they have to come forward and do their mammograms stringently from the age of 40 and should not take them lightly. Should not take breast screening lightly. Because though not much is written about it, but in practice we do see that some of these women who've undergone multiple cycles and have been bombarded with so much of hormones do tend to develop these, aggressive
these women
ovarian and breast
cancer. So it's not before 40, the screening.
No, there's no evidence to
no
guidelines to recommend that.
But
So at least if they can start by 40, and of course, clinical breast examination, self-examination. They can do their self-examination. Any little change, they can immediately rush, get an ultrasound done. And if the ultrasound shows something suspicious, we'll anyway go back and do a mammography. So self-breast examination, being aware of how your breast feels through your cycle. So all this is important. They need to be more watchful, let me put it that way. Than the normal population. They need to be more watchful of their breast and how it feels, and then be strict with their screening protocol.
I think they should be educated about this. At least they should know that they should start screening strictly at 40.
Yes.
They can't ignore like other general population.
These women, actually, there's no guidelines for having exposure to so many things, but from the...
So if a pregnant woman finds a lump, so what's the protocol? Like, how should she go about? Pregnant woman.
So if she's pregnant, she's going to present to the gynecologist, and after palpation, they should at least do an ultrasound scan to make sure that it is only a pregnancy-related breast lump, and make sure that it is that, because pregnancy-associated breast cancer is an entity.
Correct.
And especially if she's saying that she noticed it during pregnancy and it is rapidly increasing in size, then definitely it needs radiological evaluation and ultrasound should be done. And if the radiologist has even 1% suspicion that this may turn out to be a malignancy, you should immediately do a biopsy and prove that, whether it's a cancer or not. Yeah. So
not an MRI.
All lumps in pregnancy,
of course,
are milk lumps.
That's what.
As people think. No.
That is what. That holds good even for lactational lumps.
So pregnancy-associated breast cancer, by definition, is pregnancy to end of first year of delivery.
Okay.
1 year of lactation.
So it includes a broad...
Yes. So pregnancy plus 1 year after delivery, by definition, is pregnancy-associated breast cancer. So any cancer developing in this period becomes a pregnancy-associated breast cancer. And unfortunately, obviously the women are young and these are extremely aggressive cancers. So don't ignore a lump in the breast and brush it off as a milk lump, as understood by lay people.
Exactly.
Just get a simple ultrasound done. That will sort most issues.
Okay.
Yeah, it's pretty similar practice, but if the lump is they think it's of a low risk, like a fibroadenoma or something like that. They follow the patient up until the pregnancy is over, and they redo the ultrasound and then do a routine mammogram at the end of the day. But definitely there's a subset of the postpartum because of the hormonal exposure in the elderly primaries, particularly, you have these aggressive cancers.
And MRI can't be done in
During pregnancy.
Only
Oh,
ultrasound. Yeah.
exactly.
Can't get contrast.
Contrast. Right, right. So now coming to demystifying the myths and revealing the facts. So I'm going to pose, it's kind of a rapid fire, 4 questions to each of you. So I have no family history, so I don't need screening.
No, that's not true. Every woman who is over the age of 40 needs to get mammographic screening done, because 80% of cancers are sporadic. Only a 15 to 20% subset of cancers are familial. The rest are sporadic. So not having a family history doesn't make you sick.
Correct. Mammograms are too high in radiation.
No, not at all. It's equivalent to a dental X-ray, or just about 2 years of natural radiation. So that's a myth, complete myth, that there's too much radiation in mammography and hence we should not get it done. That's not true at all.
A mammogram will guarantee I don't have cancer.
It cannot guarantee, because the sensitivity of mammography is anywhere between 85 to 90. And if your breast is dense, then we add an ultrasound along with your mammogram. So that increases the sensitivity to about 90 to 92%. But if your breast is extremely dense, which we call category D, where the breast is full of white tissue, then definitely the sensitivity of mammography drops a bit. So we do add ultrasound to that, and then the sensitivity comes to about 90 to 92%. So there is definitely a 5 to 6% chance.
Still risk.
Yeah, but still it may be missed, despite the best machines and the best pair of eyes.
That's
so we call
quite
it
scary.
interval cancers. These are called interval cancers.
Right. Between the screening.
Yeah. So it's missed because of various factors. So these come up as interval cancers.
Yeah, that's quite scary. Like, only older women need to worry about breast cancer. That's total.
That's a myth. I think there's cancer. I feel after 30 years of experience that every woman is at risk for breast cancer. Either genetic, which could be missed because someone in your family had cancer and you did not notice that. And also the entire huge amount of the 80% of the sporadic cancer related to indirectly related to nutrition, hormones, everything together. So everyone is at risk.
So coming to you, Mamatha, if I don't feel a lump, I don't have cancer.
That's not true, because there are certain breast cancers like invasive lobular carcinomas and certainly some apocrine cancers. They do not present with a lump. Unfortunately, radiologists do miss those things. But for that point, we need an expert radiologist. We're looking at the densities, what they have, and malignant densities. And then for us, their second opinion is one of the most important things. And in your report, you do the rat path correlation, and then you show it to another person. And the second radiologist name has to be on the report as well.
So the whole point is that by the time it becomes a lump can be felt, it's easily 2 centimeters.
Yeah.
And, and then, I think we need to talk about the axilla to the armpit.
Right.
Yeah.
So if the cancer is less than 1.5 centimeters and the axilla, which is the first station of spread of breast cancer, is negative, which means cancer has not gone out of the breast, then the 5-year survival rate is close to 95%. And if the cancer is 1 centimeter and axilla is negative, it's almost 98% 5-year survival, 12-year survival actually, not even 5. You talk about 12-year survival, when you're talking about
1 centimeter.
So if you're waiting for a lump to form, you're waiting for the cancer to be at least 2.5 centimeters. And it would have already spread to the armpit, which increases the stage of the disease and hence the prognosis too.
Obviously.
So
we call
doesn't protect us.
We call something called the occult cancers. Okay,
Yes.
so in sentinel node biopsies, the patient we pick up the cancers in the sentinel lymph nodes, and that's when they relook of the mammogram is done, and they also do an additional MRI and just to make sure that the tumor is felt somewhere in the breast. And if they're not seen in the breast tissue, it is assumed that the tumor is arising from the axilla, and the sentinel node being the proximity of the axilla, that could be the origin of it as well. So, and the patient is staged accordingly with that. So,
mammogram is only needed if you have symptoms.
That is not true.
Yeah, obviously.
The entire podcast we have been discussing.
Yeah, exactly. All lumps during lactation are normal. Like that also we had already covered, I think. And is breast pain a symptom of breast cancer?
Usually not. 90 to 95% of the time, breast pain is not a symptom of breast cancer.
Until it's advanced.
It's very, very advanced. So that's also, unfortunately, because the women don't have pain, they don't come to you.
Yeah.
These are painless lumps in the breast. And if you ask the woman, what are you doing all this while? There's a 5 centimeter tumor in the breast. And the answer you get is, yeah, it was there. It wasn't cause. It was not paining. So it was not a painful lump. So I didn't come. So usually breast cancers are painless unless they have become very, very advanced, infiltrated the skin or the muscles or in the axilla when they form a big lump. Usually pain is not a symptom of breast cancer. Rarely, a certain type of cancers can present like inflammation of the breast, a subset called the inflammatory
breast cancers. Yeah.
So they can tend to be a little sore and painful and things like that, but that's an aggressive breast cancer. But most of the times, pain is not a symptom of breast cancer. And usually, women who have this cyclical pain in the breast, that's one of the commonest reasons why they come for PHA.
Yeah, exactly. Exactly.
Out of 100 who come to the clinic, about 80% of them say that I've come because I have pain in the breast.
Exactly.
So you're lucky. It's all right. You're normal.
Correct.
It's normal to have pain in the breast because we spoke about the cyclical change.
Correct.
So sometimes there can be some distended fluid bubbles. We call them cysts. So they can get infected and cause slight pain. So the reason we do a scan is to rule out other things.
Correct.
And not to find the actual reason for the pain, because usually the pain is hormonal.
Correct.
And bilateral, sometimes it can be a little more in one of the sides.
Yeah.
But then usually it is hormonal.
Yeah. So just to talk a little bit of the breast pain, it's called mastalgia.
Yeah.
So mastalgia can be predominantly normal pain because of macromastia with big breasts. And so women complain about it. And as you said, the advanced cancers can present with it. But within the breast tissue, we have other parts like nerves, like fat, and all these things like a neuroma, a tumor that's arising from the nerve itself can cause the mastalgia, severe mastalgia as well, which can be picked up by the mammograms as well. So, those unusual tumors other than the breast cancers can present with mastalgias, and those are the ones that can be picked up as well.
So with this, we end this podcast and such an insightful conversations with you both. I have learned so much from you both, and thank you so much. I can't thank you enough for all this. So having you, Mamatha, it's an honor. Srikala, my little sister. So we look forward for more such conversations for our audience and for us too, in fact. And I take this opportunity to tell you that we are collaborating with Sindhu Hospitals, where Dr. Srikala is the chief radiologist. It's because we at True Med truly value the patient's time, effort, and the money they give to us for the tests we offer. So for any mammography patient who walks in, it will be done at Sindhu Hospitals, because we always believe an expert will always give the best to the patient. Thank you.
Thank you so much, Dr.
Yeah.
I just want to mention that I come from US, and India has, after listening to all of you, it has really picked up on the cancer treatments, or even the diagnostics as well.
Mhm.
So I'm really learned a lot from today, and thank you so much for hosting me.
Yeah,
So
it's such a pleasure. Yeah. So after all this podcast, the gist of the podcast revolves around this single line: early detection saves lives. Screening mammography is the tool for early detection of breast cancer. So, there is a widespread misconception that breast cancer occurs in only those with family history. It's not so. Only 20% of breast cancers are hereditary. The rest, 80%, are sporadic. So, when do they actually have to get this done? First week after the period, because the breasts feel lighter. And where? Yeah, a dedicated breast unit with proper mammography machine, 3D digital machine with an experienced radiologist, because early cancers are small cancers, baby cancers, which needs to be detected, which will be detected only by an experienced radiologist who does it on a regular basis. So that's the center you need to go to get your screening done. It shouldn't be an eyewash. Coming to genetic testing, there's much talk about BRCA1 and BRCA2. So who should undergo? Well, there's a woman who wants to get genetic testing for the sake of it. No. It should be done if she has had a relative, first degree relative, mother or grandmother, who had breast cancer or ovarian cancer and who passed away because of that. Then, okay, she might be an ideal candidate, but always consult your genetic counselor for that. And then, if there is a woman who has been diagnosed with breast cancer, then probably she has to undergo genetic testing, because to advocate genetic testing to her offspring, like her daughter, or for that matter, her son too, it's important that she tests positive. If she tests positive for BRCA1 or BRCA2, then it sounds logical for her offsprings also to get tested to assess their risk of getting breast cancer. So in case if she doesn't get positive for doesn't get tested positive for BRCA1 or 2, there's no need for her offsprings to undergo the genetic testing. Then coming to male breast cancer, yeah, the incidence is quite low, but then that doesn't mean that they are foolproof for getting breast cancer. If his mother has been diagnosed with breast cancer, and if her mother tests positive for BRCA1 and 2, so it's important that the son also undergoes genetic testing a bit early, around 25-30, because there's an entity called chemoprevention, which is meant to delay the occurrence of cancer, because they have a risk of getting breast cancer too. Then, pregnancy and lactation. Yeah, if you see a lump, don't brush them off as milk lumps, because a small cancer might coexist with the milk lumps. Please consult your obstetrician or your consultant to clear the doubt. Breast pain, it's not at all a symptom of breast cancer. Of course it is, but in quite advanced stages. So don't get panicked if you have breast pain. It's a very, very common cause called mastalgia. Coming to nipple discharge, Yes. Unilateral bloody nipple discharge? Yeah. Consult your doctor immediately. Thank you.